couldn't see where he was, but I guess he was at the back. And he does the introductions, and he's like, and now, Dr. Susan Little! And it's like, what the?
Wow.
Sorry for saying Sorry Media presents the Purr Podcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Jolle Kirpensteijn, talented surgeon and social media geek.
Hi, this is Dr. Susan Little.
And this is Dr. Jolle Kirpensteijn. This is the Purr Podcast.
That was a pretty good beginning for us.
It was a great
beginning.
Yeah,
we have trouble with beginnings.
Yes. No,
yeah.
we. How do you mean we?
I have trouble with beginnings. So
Are you reflecting now?
I'm reflecting.
Okay.
So Jolle has described me on a recent podcast as looking like a deer in the headlights because I never know like who's supposed to start. And one time we both got kind of stuck. And nobody started. There was an awkward pause. Ooh. And so our guest decided to start the podcast for us.
Oh, that's amazing.
Who
was the guest? You guess.
You can guess. Who amongst our little circle of friends would jump in and
over immediately.
Yeah.
Without
who do you
even
think
asking.
would do it?
Justine?
Almost. It's more in the other gender type.
Eric?
Like
maybe Eric. Uncle Eric.
Yeah.
Uncle Eric.
E.
No. I like Uncle E, you know.
Yeah.
It's like, it has this dark connotation with it. But yeah,
so Uncle Eric filled the gap and started the podcast.
I mean, that's his jam.
I know.
That's his jam.
So he saved us. So we always had this kind of, I thought that was a smooth start though.
Yes. I do need to tone the
Are we
sound
too
down
loud?
a little bit. Yeah, we are a little
We're having
bit.
too much fun?
Okay. No, that's okay.
Should I lean back?
It's fine. No, it's just a laughter thing.
You're supposed to always lean in.
Lean in.
Yeah, lean in, Susan. Yeah, that's exactly
Lean in.
So we have a wonderful guest for today, and maybe you can introduce yourself.
Yeah.
Hey, everybody. Christopher Byers.
Oh, yay! We're so happy.
Chris
we
Byers.
finally had a chance to have you.
Yes,
Come
it's
chat.
finally aligned.
But
Yay.
I think people probably know you by your other name.
Yeah. What's your social media
I guess
handle?
that other name is Critical Care DVM.
Yeah.
Yay.
Great name, by the way.
Thank you. It
Yeah.
comes from a faculty member, actually.
Really, you stole it?
In school,
Yeah.
I never thought I was going to do internal medicine.
So where'd you go to school?
I went to school
Let's
at
back
Cornell.
up.
Oh, well, I did
Cornell.
undergrad at Colorado State
Yeah.
and then went to Cornell.
Yeah.
Cornell.
And I always knew I was going to do emergency critical care.
You
Really?
did.
Always knew I was going to do emergency and critical care.
You did.
And then there was a faculty member during medicine rotation that literally said to me, okay, Chris, we know you're the critical care DVM of the class, but you're really good at medicine and you should consider doing
Internal medicine.
an internal medicine residency. And so that's always stuck. And he's actually honestly the reason I did an internal medicine residency. When somebody that you respect so much says you're good at something, you're like, okay, I'll do it.
Okay. That was the start.
So where'd you do your residency?
So I did my residencies at Veterinary Referral Associates in Gaithersburg, Maryland.
Oh, okay.
So that's a private practice
It was a
residency.
private practice residency done concurrently.
Why you did two in the time span of one?
So we are always
Wow.
interested in people's like educational path, and we've heard some really interesting, but I've not heard this
This
one
one
yet.
was speeded up though.
Yeah.
You know,
Yeah.
we had a person that
Yesterday,
took
25 years.
of education.
But it was
years.
multiple degrees, but...
Okay,
6
let's
years
count.
crammed into...
Okay, let's
Okay,
count
so
from the beginning.
undergrad.
So 4 years of undergrad,
Four.
4 years of DVM,
Eight.
1 year of internship in
Nine.
Long Island,
Yeah.
and then 4 years of residency.
13.
13. Wow, that's a record. And
I
a
think
double
that's-
dip here.
that's
huh?
one of the shortest-
Double dipping.
Pretty good.
That's
So what was it
amazing.
like to manage 2 residencies?
Oh, gosh,
I honestly, is this a common
It's
thing?
mind-boggling.
This is
No,
new to
no.
me.
It actually doesn't exist anymore.
Yeah. Was it a particular program at that?
Yeah, there were, to my knowledge, there were 3 double residency programs at that time. 2 were critical care and medicine, 1 where I did mine, the other at the Animal Medical Center.
Okay.
And then there was the combined critical care anesthesiology at Penn.
Okay, wow.
And I think that's what
That's it.
our colleague Ben Brainerd did.
He did that one. Yeah.
So
Wow.
that's really interesting. So that's double shift duties, double everything, or how? Oh my gosh!
You got it.
Double exam.
And then only year 1 do you not have to take an exam.
Oh yes.
At the end of year 2, you take your medicine qualifier.
Yeah.
Or general exam, as they call it now.
Yeah.
General exam.
Third year, you take your critical care certifying exam, and at the end of your 4th year, you take your medicine certifying exam. What that meant was, if you passed, thankfully I did, your critical care exam at the end of your 3rd year, you were the lowest paid criticalist in the entire world for your 4th year of residency.
Yeah, although I do have to say, Chris, I feel really bad for you here, but I do have to say,
he says with a smile.
I was looking at the AVMA State of the Profession, and they showed that interns make now $30,000 a year in average. And
that's not a lot of money.
I started my internship, I got $13,500.
$13,500. But it probably went further. Like
it was the same year. It was the same emergency duties. It was the same stuff. It didn't go any farther than that.
No.
So
I mean, your money might have bought more.
Yeah,
because that was like a long
remember
time ago.
I know it was a long time ago.
They're gonna start fighting.
Yeah, I know. This is what happens. This was happened. So I can't kick her because in between.
Well, my hat is definitely off to you. That's
those training programs are no longer allowed.
Yeah.
They redid things at all the colleges, so now it's residency fellowship.
Yeah, residencies and fellowships.
And that's, I did my fellowship too in surgical oncology, and I have a fellowship in minimal invasive. But I think that's probably the better way to do it.
I agree.
Because,
I honestly don't know if I would do it again. I would always do critical care. I don't know if I would do medicine.
Really?
I think I would probably either do anesthesiology, because I do like critical anesthesia.
Yeah.
But I might do a PhD in hematology immunology. That's really what I love.
That's cool. That's cool. And so who were your teachers? So who were your main characters
Mentors,
in your life?
Yeah.
My main mentor in undergrad was somebody named Tom Field. He's an animal sciences professor. And interestingly enough, he was at Colorado State and now is a faculty member at the University of Nebraska, where I live in Nebraska now. So we're still in touch.
Yeah.
In college, it was Dr. Nishi Dupa, who is a criticalist internist, and she was just an absolute phenomenal mentor. I loved all the faculty, to be honest, and my 2 favorite rotations in vet school were large animal medicine and large animal surgery. And for me to say large animal surgery, that's a lot, but I did love it because it was so novel to me. I didn't grow up around large animals, so
I loved my equine rotation because I did not grow up around horses, and it was like an amazing world to me. I get that.
I have one too. And during my vet school, one of my favorite rotations was cutting cow hooves. It was a whole week.
Hoof trimming.
Hoof trimming of
Hoof
cows.
care.
And it was a whole week, and I was in the countryside, and I loved it.
So I have a funny story about hoof trimming.
There's probably a lot of funny hoof trimming stories.
The ambulatory professors didn't really get me.
No.
And the section chief...
They didn't get me either, so that's okay.
The section chief would bring us all over, and we had 2 ambulatory rotations, and one of them, it was all small animal people.
Yeah.
And we were super excited because we're just sponges, right?
Yeah.
He brings us over to this downer cow, and he asks me what I should do with the downer cow. And you guys know that I'm not precocious at all. So I said, well, I know you want me to say, give hypertonic saline, dexamethasone, hypertonic saline, glucose, calcium.
Yeah,
the calcium thing. I was
waiting for the calcium.
And, all these things that you're supposed to do. 1, 2, 3, 4. But I said, but for me, you haven't proven that this cow is hypocalcemic. You haven't proven that this cow is hypoglycemic. You haven't proven that hypertonic saline is the fluid of choice compared to an isotonic crystalloid. yada, yada, yada.
Oh, that
And
came
he
over
looks
well.
at me and says, you want to be an internist,
Don't
don't
you?"
And I was like,
Yeah.
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 Uh,
Way
It's
to
like,
make friends.
Well, those are some interesting points. Why don't you go trim the hooves of those cows? That pen over there.
Hence the hoof trimming. Banished to hoof
yes,
trimming.
Yes, all right. That was the end of your
I was banned.
ambulatory career right there. All right.
I
good,
hear
good,
ya.
good. So this podcast is really about cats.
Which
Just
you would
wanna
never
say.
know.
Exactly.
Not a lot of
So-
hoof trimming in feline medicine.
Yes.
Yeah, not
So
a lot of hoof
after you
trimming.
did your residency and your internships and
Yeah.
that sort of things, what happened with you?
So I actually stayed on at my residency training site
In Maryland.
in Maryland. The person, right, it was weird because the person who was the head of ICU stepped down as I was finishing my residency, and I was made head of ICU fresh out of residency.
Oh, wow.
So I never even had a junior attending position,
Oh.
which was a challenge, and I'm glad I had it. And
Yeah,
it
but
wasn't
it's-
always smooth,
No,
but
yeah.
yeah.
Baptism of fire.
It helped me
Yeah,
grow.
Yeah.
Yeah. And
No,
how busy was that ICU? Because I have to say I'm only used to ICUs in academic settings, and I know that they can be pretty busy. But I bet that they in private setting they're really busy too.
So that hospital, and I never verified this, I just took the word of my mentors, was the largest private practice ECC training site
Wow.
in private practice.
Wow.
At the time, we had 4 critical care faculty members and 5 or 6 critical care residents.
And I did
Wow.
find out I'm passively corrected by saying ICU. I need to say ECC. Is that better?
ECC, and then of course you can, because you don't want to, I mean, I don't, my passion is more in critical care,
Yeah.
but there are many colleagues in the critical care college that are more passionate about emergency medicine, so
There you go.
we
Ah,
gotta,
so
we want to be
inclusive.
inclusive.
We'll be
ECC.
inclusive. Okay.
ECC.
We have to change our
I
terminology.
stand corrected.
Yep.
Yes,
Change our
yes.
terminology.
So, and so how long did you do that?
So I stayed with that hospital for 4 years, and in February of 2011, I left and moved to Nebraska.
Oh,
Why
wow.
Nebraska?
I moved to Nebraska
Quite a change.
to work at the private practice hospital that was owned and operated by Kansas State.
Uh-huh.
So kind of had the best of both worlds, and then I got to keep working in private practice and avoid some of the bureaucratic red tape, so to speak, that comes with a pure academic position,
Yep.
but also got to teach students. It was actually a really neat program in that the hospital was purely nonprofit,
Yeah.
and the university owned a duplex, a men's side and a women's side, and students could come do an elective rotation in either medicine or surgery. But the unique thing was, because we did not have house officers, and we only took one student in surgery and one student in medicine, it was one-on-one.
Wow. That's good.
Got to do a
No
lot.
fighting. So think about being that student on surgery.
Yep.
You got to do
It's pretty amazing. Everything.
dozens of
Yep.
first assistant surgeries as a student
Yeah.
during that rotation. So it's very, very popular.
I think Roger Finland started with that practice.
That
Yeah.
is the one who opened it. Yes.
Yeah.
Lovely.
And
Yeah.
Roger Finland was my surgery mentor.
Really?
Yeah, so he was my surgery resident advisor and leader. And I owe my career to Roger.
Oh,
So-
you know, we live in a small world.
We do.
Yeah, he was
Veterinary
my boss.
medicine's a small world.
Yes, and I have to say hello to Roger over the podcast. Hi, Roger, if you're listening. Big plug for you. He's at the Ohio State
He
University
is
now.
now at the Ohio State. So that was the next step.
And
he
I called him
was
Uncle Rog.
Uncle Roger. I don't know if I could ever call him Uncle Roger. He was just the boss.
Yes.
But in 2015, things changed at the university.
Yeah.
They sold the practice
Yeah.
to a corporate entity.
Yeah.
And Roger moved from Manhattan
Yes.
to Columbus.
The Ohio State, yeah.
And I'd fallen in love with Omaha.
So you're really close to me, as a matter of fact.
We're very close.
So okay, we need to meet on Midwest soil. Then,
Yes,
I think.
absolutely.
Because how long?
It's only a couple hours away.
Yeah, it's a couple-hour drive. Huh?
Yeah.
So that's good. Not in the winter though. I'm not doing that.
No.
He's not
I'm
a
in
winter
hibernation.
person.
I'm right there with him.
Yes,
He's not a winter
we
person.
meet each other then in warmer cultures and climates. But so no, that's really cool. So now you're in Omaha, Nebraska, and as a Kansan right now, Jolle Kirpensteijn, I have to say that it is much nicer living in Kansas right now than it used to be when I was much younger. And so I really enjoy it, as a matter of fact. I enjoy living in the Midwest. People are
You're
super
there at
nice.
the right time.
I love Omaha, and as a New Hampshire Seacoast person, but most people don't know where Rochester, New Hampshire is, so I say about an hour north of Boston.
Yeah.
So as an East Coaster, if I ever thought I would say that I was going to live in Omaha.
Because that's quite a shift, cultural shift.
When you say Boston, we can hear it a little bit.
So my team members laugh at me because the accent usually comes out either when I'm inebriated, which they don't get to see, or when I'm exhausted. Exhaustion brings it out. Yeah. Or when I'm mad. I can't lie. It really does come out when I get mad.
So I'm an East Coast of Canada person. And my accent has flattened out because I've lived in Ontario a long time. But when I go home...
Oh, gosh.
Isn't it amazing how much it comes out?
It's back.
I might come in the morning, one morning to the hospital, and obviously I'm not tired, I'm not drunk,
hopefully,
and I'm not mad. And they're like, did you talk to your parents last night?
Yeah.
How'd you know? Because we can hear it.
We can hear it. Yeah, that's me to a T.
Yeah, when Susan starts talking of a Grand Strawberry or whatever that thing is, she immediately gets an accent.
Because there's a giant strawberry that's a tourist attraction. He just can't get over it.
Yes, a tourist attraction,
Well, interestingly, my dad is from Brule Beach, Nova Scotia.
Brule! Go away.
Okay, folks on the cat thing.
Go away.
Folks on the cat thing.
We would go to Brule Beach every summer.
Kidding.
Yeah.
We're neighbors.
I know.
Oh.
Isn't it crazy?
That is crazy. Have you been back to Nova Scotia?
Not for about a decade.
Okay, come visit me. I live in Truro these days.
Okay, dear listeners, I'm very sorry.
Sorry. That's what happens when you get two people with maritime connections together. Just excuse us. We're going to go chat amongst ourselves.
So we are going to focus on cats. Emergency critical care things, right?
20 minutes in, we're getting around to the cats.
Yes. So we had Justine Lee, the awesome Justine Lee, on the podcast.
Wonderful.
We talked a little bit about emergency
a lot of
critical
toxicities
care.
we talked with her and poisonings and stuff.
We did. So, and we talked about what are the top things that you see in emergency critical care in cats. You don't like surgery?
I don't like doing surgery. I like being in the operating room with the anesthesia associated with those patients.
So can we talk about that then a little bit?
Sure.
About anesthesia and critical care patients, because that is a cool topic. So I'm obviously a surgeon, and I loved emergency surgery because that was the only time that I could do whatever I wanted to do. Because it is in the middle of the night. I have not 100 people around me telling me that I have to hurry and that sort of thing. So, and it's always the coolest cases that come up. So these are often trauma cases, sick cases, and you depend on your critical care anesthesiologist so much because I always say they save the patients. I don't. I just fix them. They save them.
I think it's true teamwork, because I do think one of my primary responsibilities outside of the actual patient is letting you as the surgeon cut. You shouldn't have to worry about anything
but cutting.
And if you do have to worry about more than cutting, I'm not doing my job.
Although I do remember that sometimes the anesthesiologists were screaming at me about something I had to do. For instance, when I suddenly had to convert to a open cardiac massage, and not yesterday, now. And then a lot of expletives followed. Yeah.
I mean, I may have said "so like the wind" many times. Get this patient off the table now.
That happens. That happens.
But,
yeah. Yeah. So here's a common scenario. You've got your very sick blocked cat, right? So it must be a dime a dozen.
Oh,
right?
Very much so.
Right?
Very much so.
Okay, so let's talk about approach to those guys.
So I think one of the things that a lot of our colleagues are really scared to do when these sick, late decompensatory shock kiddos comes in is they're afraid to do a decompressive cystocentesis.
Stick a needle in it.
Just deflate the damn bladder.
Oh, I'm so glad you said that.
It buys so much time. It makes them feel better. And it actually facilitates catheterization because you've reduced that intraluminal pressure. If you combine decompressive cystocentesis with a very simple coccygeal epidural.
I love you.
Oh, and how about we just insert a little bit of atracurium in the urethra? It makes that catheterization process go so much more smoothly. You don't have to use as much sedative to unblock them, which is obviously better for these very decompensated patients.
Yeah, I love that you said those things.
And when I bring this up, the first question that I get in my lectures is, but aren't you afraid for rupturing the bladder?
The simple answer is no, and there was a paper done.
There's a couple, I think one out of...
Is it Minnesota?
Minnesota.
Lisa Powell and colleagues.
And then there is another one. There's one, maybe Texas or so. Anyway, I think there's two.
I can just remember the Lisa Powell paper is like 45, 44 cats. Every single cat had a decompressive cystocentesis. Not a single one of them had a uroabdomen.
No.
Exactly.
No.
So, even if you have a little leakage, it doesn't matter.
It doesn't matter. No.
Actually, they're probably going to have a little bit of transmural exudation anyway.
And I think they found that, didn't they? Because I think, is that the study where they ultrasounded them before and after?
Yeah.
And they found some cats already had some fluid, presumably urine, and it's probably just transmural.
Exactly.
And
from the pressure.
This is such a cool topic, but we are at 25 minutes. So
I know.
We
had too much fun.
I know we did have a lot of fun in this first episode, but that means that we have a second episode.
So it's a nice teaser. To be continued, The Blocked Cat.
The
dun,
blocked
dun,
cat.
dun.
And we'll talk about more things because, critical care DVM is also very famous because of other things that you do.
Yeah, we want to talk about your social media life a little bit.
One thing I love about you is your blogs. I mean,
Thanks.
I am totally addicted to them. And as you know, I share almost all of them.
Oh, wow. Thank you.
My,
it's fun. It's really
media.
a passion of mine to educate. And I'll share in the next episode how it got started.
We'll talk more about that.
Awesome. So see you all next week or the week after.
Yeah. We'll be back.
All right.
Bye-bye.
Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August, Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatVetSusan. Dr. Jolle Kirpenstein is a diplomate of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Jolle works currently at Hill's Pet Nutrition. You can follow him on social media with the handle @GVETSX. The opinions of this podcast are those by Dr. Susan Little and Dr. Jolle Kirpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @Purr Podcast.